So for those of you who have never met, Keith Bachmann, I'm one of the pediatric orthopedic surgeons here. This is now year 7. For the peds folks, I saw Bettina. Anybody else in the room that does pediatrics? Mark Abel's there. Task maybe marginally raised his hand. That's really good. This is going to hit home nicely for everybody. So, but what has happened recently in the treatment of idiopathic scoliosis? Dr. Didak showed nicely that growth modulation, and that's always sort of the holy grail within peds, is growth modulation, or that's kind of how we understand growth pretty well. And so, trying to get that into the spine space has been a goal of a lot of folks for a long time. And so vertebral body tethering, show of hands if anybody's even heard of this concept a little bit. I know Dr. Zura's got some folks down at his shop doing it a lot. And so, I figured we would give a talk about scoliosis to try to inform everybody else, just in case you happen to see some people. These are my disclosures. None of them have to do with really much other than I'm a member of HARM, so let's not bag on it too much. And then I do the tiniest little bit of consulting work. So based on the prior show of hands, I'm going to guess that not many people are going to raise their hand for seeing this patient in their office in 2023. Am I the only one? We got another one. All right, good. Excellent. So everybody else, go ahead and start your break early. Just go get some coffee. Residents, you need to stay, but no. So what I want to do first is just sort of define the scope of the problem. And so scoliosis, when we look, there's some really good work that came out of Iowa following patients for a really long time. So 40-year, 50-year follow-up to try to get a sense of whether or not that patient is going to have a higher risk of mortality, because there were some studies done initially in Sweden where those patients were thinking, and the people who are taking care of them were thinking that they would die early from their scoliosis. And so obviously, if you're going to have a shortened life expectancy, much bigger problem. And so in that study that Dr. Weinstein, as well as initially started by Dr. Ponsetti, who's best known for his treatment of clubfoot with clubfoot casting, but also initiated this trial that followed these patients over time. They looked at this population of patients with scoliosis in Iowa, and then we're going to follow them for 50 years. And so we've got this large group of patients, current Cobb on the left, Cobb angles at maturity on the right, just following over time. And when we look, they certainly did not find everybody. Trying to find patients 50 years later is certainly difficult. But they did some adjustments and essentially found that they did not think that there was any increase in death rate in the scoliosis population relative to, none of these patients had surgery, in the scoliosis population relative to the patients who were just Iowans at the time. And so they had one patient with a very, very, very large curve that they think they attributed the death to scoliosis, and then 2 others that they considered it possible, although those patients had a cancer diagnosis in addition to their pulmonary failure that was maybe multifactorial with their scoliosis. And from an exam standpoint, these patients can still move very well when you look at 50 years. And so the real take home of that paper was that these patients don't seem to die from adolescent scoliosis, late onset idiopathic scoliosis. We're not talking about early onset. We're not talking about kids with congenital scoliosis. We're not talking about anybody that has another diagnosis and scoliosis, just the adolescent scoliosis population. From a pulmonary function standpoint, certainly the larger the curve, patients started to report shortness of breath. Interestingly, smoking was not related to shortness of breath symptoms in either group. So even in the patients with scoliosis, smoker, non-smoker, didn't seem to make a difference. But certainly larger degrees of rotation in the scoliosis patients actually trumped their curve magnitude of whether they would have shortness of breath. And if they had a Cobb angle of greater than 50 at maturity, this became a pretty good predictor. So I think a lot of the residents and everybody else in the room probably knows this study more as the study that we basically talk to patients about surgery if their curve is at 50 degrees. That's a little bit of a distillation, I think, from this study. But the other thing we want to look at is then pain. So back pain, onset of back pain, incidence of back pain in this population. I think a lot of people in the room treat adults for sure. And we all know that back pain becomes a sort of a way of life as you get older, and certainly into older generation. The older you get, the more likely you're going to have back pain. And that certainly is true in the scoliosis population, and a little bit more likely in the scoliosis population. They also looked at these patients for functional capacity. So scoliosis patients could do, on average, 14 of 15 regular daily activities compared to 15 of 15 in the control patients, and the frequency very similar. and the rate of feeling as though they had disability was actually very similar to the other group. And once you control for pain, there was no difference. Depression and body satisfaction, scoliosis patients and controls in terms of depression, very similar. Body satisfaction was a little worse in the patients with scoliosis. So a lot of really good information in that article for following patients and trying to have an understanding when you're treating patients early in life, and a lot of the goals, and you talk to families, and a lot of the goal is, well, I want to set them up for the most success in the future. Understanding what that future might hold is important to understand as we then work backwards to say, what should we do now to treat this? And so the commentary from the authors was that there seemed to be no link to mortality, pulmonary, or cardiac conditions for this late onset, or what we now call adolescent idiopathic scoliosis. Only thoracic apices with curves of greater than 100 degrees increased any of those physiologic risks. And the prevalence from a pain standpoint was certainly higher than the surrounding population, but only considered a mild increase. And their ultimate final conclusion was that the recommendation of bracing and or surgery must be made on an individual basis, with the patient and family well informed of the natural history of the disease. So then we get to the new kids on the block. So in 2023, there's a couple new options when we're trying to treat these patients with scoliosis. The picture in the middle is vertebral body tethering. So we put screws in the front of the spine. And then I don't know if you can tell, but that's a little sort of rope-like cord. It's a poly cord that connects these screws, attempting to provide tension on the concavity of the curve and allow the convexity to grow into a straightened position. And then on the right side here, this is a device called an ApiFix. Those of you who are familiar with Harrington instrumentation in the past, this is effectively fancy Harrington instrumentation that can still actually ratchet and increase over time. So these are really the newer treatment options that we have when we look at scoliosis. So the goal of vertebral body tethering is harnessing that remaining growth to achieve correction. So you can see an example here from the Yellow Journal, Stéphane Parent up in Montreal. So the early results after achieving HDE status from the FDA, because the instrumentation for this was initially stolen, not really, but repurposed from Denosys, which was a non-fusion option for lumbar spine. And so when I was in fellowship in San Diego, we were putting in Denosys because it's designed for adults. The screws came in 5mm increments. So the best part about the cases was using the steel cutting wheel that you would have to individually cut every single screw to size. And so we got to have fireworks in the operating room as you have this kid's chest open. That was always exciting. And so the interim results from the FDA IDE study, you can see actually decent outcomes, but the numbers when we look at overall sagittal balance, coronal balance, those sorts of things, we'll get into more comparing some of the two other options. So other early VBT results, when we look 112 cases, really big slide. Important to note here, and this will be a relatively common theme. So for these folks in Montreal, success they considered in 80 cases, failure they considered in 32 cases, mostly because of the major coronal cob and then their success groups. So you can see whether or not this was actually able to control the cob, percent of success for the group. And so we find that at times when you're trying to harness growth, if you don't do it appropriately, they can end up with further change there. So I worked with Dr. Newton. He was one of my mentors in fellowship. He was one of our visiting professors here, gave some great talks about scoliosis. So he did a comparison early on, comparing to spinal fusion at 2 to 5 years post-op. And so when we look from again, sorry, busy table slide here, but when you look at main thoracic cob, pre-op, first post-op, and then follow-up, you can see that numbers-wise, they're relatively modest in terms of the improvement that you can get in the tethering group. And that seems to be a common trend here. So when you look at the fusion group, again, similar starting number, improvement and maintenance of that improvement. And so when you talk through then between group comparisons, the fusion group really comes out on top when we talk about maintaining that correction. And so when we look at main thoracic, this is first post-op down to 34 and 12. When you look at final follow-up, 33 versus 16. And so some modest improvement in the tethering group, but it doesn't compare to the thoracic group in terms of fusion, comparing to the fusion group in terms of correction and then maintenance of that. And so Dr. Newton, and then the other piece is also then revision procedures. So 7 revisions in the VBT group with no revisions in the fusion group. And so Dr. Newton, despite leading the charge initially in terms of a lot of the early animal studies for trying to modulate growth from a tethering standpoint, is also one of the key thought leaders really sort of tempering expectations or talking about how we really need to ensure that we're deploying this for the right people. And so, but that was just one surgeon. That was just Dr. Newton's patients looking there. And so let's look at an entire harm study group cohort. So let's take everybody in the harms study group doing tethers versus people doing fusions. And what you're going to find, and we'll skip through this for the sake of time, is that the numbers look very similar. So more modest improvement in the curve when you look at tethering comparing to fusion. So why tethered then? So we've got this modest change. It doesn't seem to last as well. Well, fusion means it doesn't move, right? So that the fact that it can maintain that fusion means that it's holding everything stable, but it's also potentially holding everything too stable. And so when we look, Michelle Marks, who's the executive director of the fundraising arm of the harm study group, somehow got approval to do x-rays on 100 patients post-op, having multiple x-rays for bending films. And what she found in this is that the segmental motion below the fused segment, it is fairly similar, but if they have fewer segments left over, more of that motion has to happen through fewer segments. And therefore, are we going to wear out those discs? Are we going to wear out those facet joints when we look lower down in the spine with non-anatomic motion that you're left with after a fusion? This holds true in forward bend. It holds true in side bend. And so then we start to see things about modic disc changes, disc degeneration. We've got non-fused segments. And these are pretty nice long-term follow-up studies out of Japan. And you can certainly see some increase in those changes when we look at facet joints. And so when you look at modic changes, the modic change group, if you have a large enough residual lumbar curve, so 30-degree curve or more, 20-degree curve, you're safe from having those modic changes, or quote unquote safe. And so certainly if you have a larger lumbar curve that you're left with when you have your with your scoliosis, then you're more likely to have a drive toward having these early degenerative changes. So this is minimum 27 years, again, long-term, and you can see some of these modic changes that are happening around this. And when you look at the questionnaire, if they have AIS versus control, self-image is still going to come out when we look at the SRS survey from that standpoint. So this holds true whether you've had surgery or not. So again, same group looking at into middle age with no surgery, and you can see disc degeneration, modic changes in the residual deformity group when comparing to the control. Always interesting, though, the percentage of patients that have residual changes in that control group. So middle age, no surgery, follow-up, same story. So can the tether solve this? So is the tether actually going to preserve enough motion that we're going to avoid some of these modic changes? I think that becomes the big question, because if we want to use a technology that doesn't seem to do as good of a job of fixing the actual scoliosis, maybe it'll solve some of the residual issues that we have with the fusion. And so the folks up in Philadelphia did some 3D motion capture on patients. This was their setup. And when you look at postoperative motion after VBT is going to be in blue. I really appreciate their color choices. I did not change that to be blue and orange. I think it's just a good color scheme. So when you look at VBT versus posterior spinal fusion, and this is extension, side bending, and rotation, the thoracic motion at 2 years post-op seems to be much better. The lumbar motion looks actually relatively similar between the two groups, whether you have a tether or whether you have a fusion. These are looking at the lowest instrumented vertebrae from that standpoint. And so when you look in summary at 2 years, no differences in the SRS scores between the two in this paper. Lost flexion in both groups. Their motion capture error they considered at 4 degrees. And so they're looking at sensors to take this out, but they felt that the motion from the VBT was marginally better when you look in the lumbar group. Second thing then is, what about the lungs? So if we're going to put these tethers in kids' chests, what's the pulmonary function going to be in the long term? So certainly, if really, really large scoliosis, is going to lead to deterioration in your pulmonary function. I don't want to do something from a surgical standpoint that's going to lead to pulmonary dysfunction for patients that don't have big enough curves that would create that problem for them. And so there's not a lot of long-term. This is about anterior spinal fusion. At 5 years, their numbers get back where they were pre-op. Unfortunately, the expectation in children is that their lung function will continue to mature until 18 to 20. And so you can see at 5 years, percent predicted is actually in decline relative to their pre-op. And so from an anterior instrumentation fusion perspective, pulmonary function decreased. There's not nearly as much when we look at tethers yet. There are patients that they have looked at for pre-op, and they're now at 1 year post-op, and they're holding their pulmonary function parameters for now. We'll be interested to see what happens with those over time. So in summary about tether, I do think that it's a promising technique. When we look at motion preservation, we're really trying to treat some of the downsides or long-term effects of a treatment that we would otherwise do. It doesn't do as good of a job in my mind of treating the actual problem of the scoliosis. If it can treat the downstream effects that we have from the scoliosis without creating more problems with the lungs, maybe it's something that we want to look to, but I certainly would temper expectations from that standpoint. So what about this APIFIX? Sort of the fancy Harrington is the way that I think about it. The group in the Netherlands looked, and certainly JBJS, a high rate of failure with this device. Now, that doesn't necessarily mean that you shouldn't do it, because the whole thing is actually mobile relative to the spine. So again, both of these are designed to try to preserve motion from that standpoint. But a lot of patients, they don't love the idea when you start talking about, half of these are going to go poorly for you. And the real question with the APIFIX is compared to the tether. The tether, we at least can demonstrate that it has growth modulation. The APIFIX, I'm not sure what changes for that patient, because these are actually indicated even for adult patients. I'm not sure what is going to change that then preserves the correction that you get in the scoliosis over time. And so there is an American registry of the first 200 cases. Pediatrics bought this from the Israeli company that designed it. And so they have not yet reached their total enrollment of those first 200. We are a site here. We've got a couple in the registry. We'll see what happens after 200 cases to see if we can get it. Both of these techniques, both vertebral body tethering and APIFIX, they have fairly limited indications. So really curves above 60 are not going to be eligible for either one of them. The APIFIX, you can only treat single curves. So I still think that moving forward, the mainstay of treatment is going to be keep the curve as small as you can with bracing while the child's growing, and then posterior spine fusion unless somebody is interested. And so there are some things as well. If anybody treats these patients, Schroth, for physical therapy, when patients ask the question, is there anything I can do that's not wearing a brace or surgery? Looking into Schroth, but there's some downsides in terms of the economic disadvantage of attempting to do Schroth. But it does seem that Schroth seems to help preserve and prevent progression when coupled with bracing. It is not a substitute for bracing. If nobody's familiar with Schroth, it's a whole bunch of body manipulation exercises aimed at attempting to control the spine from that standpoint. And then what about other alternatives? And so Richard Campbell, one of the residents here, and myself have been slowly building off of some studies that Dr. Abel was interested in about the lumbosacral takeoff angle of the spine. You can see a lot of overlap. What's in blue is somebody who had a long segment fusion, so a lumbar cob, or including into the lumbar spine, and in red is a thoracic only fusion. There's this whole group of purple here that's overlap where their lumbar cob, which is on the x-axis there, was actually the same pre-op in both groups. And so why were some surgeons choosing thoracic only fusions and some surgeons doing long segment fusions? And certainly a good way to preserve motion is to just not fuse the lumbar spine as opposed to then tethering. And so working to look at that and hopefully have a 5-year paper about this coming up, demonstrating maintenance of correction in both of the groups, and certainly improve flexibility when we look at thoracic spine. And so for me, if there's growth remaining, consider a tether if you're at a surgical number, but with hesitation. If you're able to achieve a lumbar cob less than 40, based on that predictive LSTOA formula that Dr. Abel and Dr. Novikov actually published a while ago, with a selective fusion that ends at L2 or above, then I still think posterior spine fusion is the correct answer for these patients for good, durable treatment of their scoliosis. And I think that everybody should wait with cautious optimism about further information for tether or posterior distraction. If the patient has achieved growth completion, then I think you can continue to follow the curve for change. And if they end up falling into that group that has more change, then discuss more about them with surgical options. And then really, truly the mainstay, 90 to 95% of the patients I see for adolescent scoliosis are getting a brace, maybe talking about exercises, and really hoping to hold on for that thing until they get to maturity. So any questions before I turn it over to Mark Romness?
So Keith, how many APEX cases do you think we'll do a year?
Right now, 1 or 2.
Yes, very small indication.
Because of the narrow indication window. And you actually, in order to get the patient into the registry, you have to submit the images with the bend films. They have to bend less than 50% of their major curve. Their only curve, they can only have one curve. You have to submit the images to the company. They have to validate with an external validator that they meet the criteria before they'll actually release the patient to be in the registry. So very tightly controlled because they don't want their outcomes to be bad. But how many patients fall into those ultimately, I'm not sure.
I think the number will rise once you have more data to support that. So right now, you and me both are hesitating to offer that.
Yeah, for sure.
But if we see some success, which is now, but because our magnitude is pretty much like 90% of our patients. Do they have flexibility enough? Yes, they have flexibility. What about, is it successful enough to offer to our patients or not?
Yeah.
So once we have more data, I think we'll be more comfortable offering it.
Yeah. Right now, we have one paper with 20 patients from the Netherlands. That's the only person who was not the design surgeon to release any data. Once we have the 200 registry patients from America, if that shows good results, then maybe more people will start to pick it up, and then we'll see what happens from a preservation of motion standpoint. I agree. Great.
Thanks, Steve.
All right, so I'm going to give you sort of an update on lengthening and deformity correction. What are we doing here? Got it. Can you back? Oh, there we go. All right. So welcome everybody. Thanks for coming. Great weekend ahead. I'm going to feed on what Dr. Dudek said. Standing full length films are sort of our go-to alignment. You know, it's a great way to screen lower extremity deformity. I also say if you can look at the leg, you think it's, you know, severe valgus, severe varus, but then you get the X-ray and you're like, it's really not that bad. Because clinical exams can be pretty deceiving on these. But I like these because they give you the length. They actually show you the mechanical access. You can actually look at the bone structure. You can look at the joints. You can, for us, we can see, is there growth remaining? And it kind of gives you, is there a cyst somewhere in the bone that's causing a problem? So these are nice, great screening tool, especially with the packs now. You can measure, you know, right off the imaging. It's quite accurate. EOS was kind of, this is a low dose kind of standing. It's good for weight bearing if they have a fixed contraction or something like that. The problem with this is it's really hard to access. We couldn't even get one in the battle building because a space requires. And well, they had to tear down the wall to get it in too. But again, the key thing is mechanical access. You know, in the deformity world, we think about the mechanical access from center of the head to center of the ankle. And we all do this in the operating room, you know, when we're looking at alignments type stuff too. For us, we like to break it down into the distal femur here and proximal tibia. So the LDFA and the MPTA are the kind of main measures I'm looking at when I'm looking at angular deformity in these. I also say, don't forget about the sagittal plane. You know, it's just as important. People forget about it. I've actually got one case I'll show you where it's made kind of a difference. But these numbers are important too. I think in the adult world, they're becoming more familiar with how important the tibial slope is and how that affects the knee. The other key thing I want to bring up is what's called the center rotational angulation. And that's when you're looking at deformity correction, you want to find out where the apex of the deformity is. Because anytime you're correcting deformity, the closer you are to correcting it at the axis of deformity, the less likely you are to create a secondary deformity. So a lot of what we do, sometimes we'll do these corrective osteotomies away from the deformity, but you're actually creating a secondary deformity. And I'll argue that like the proximal tibia and the distal femur opening wedge osteotomies, you're actually changing the incorrectly changing the axis of rotation and the mechanical alignment. And that's why this diagram here, you see when they did the rotation, the deformity's at the knee, but the rotation's done down here, which is where you have to do your osteotomy. But because of that, you're getting a translation in your fragment as well. And that's something that an opening wedge does not do. It doesn't give you that translation. So it's less anatomic. There's also an app, it's called the Multiplier app. It breaks down into all different types of deformities. It's a great reference. It says down here additional resources, but it includes spine, foot, fetus, height, upper and lower extremity growth things, and you go in, you type in the where the deformity is, what their age, date of birth is. You can calculate all this, and it does this for you. Now it's not super accurate, so you kind of have to double check your numbers and things like that. But it's really helped a lot in planning, what we're going to do with some of these kids. Basically, these are our treatment options: shorten the long leg, lengthen the short leg. In general, lifts they're not required. No one's really shown them that makes a big difference, in terms of hip, knee, spine, that kind of thing. But it's a simple thing to do. If they come into me and they're symptomatic, I'll say, yeah, try a lift and see how you feel. In terms of lifts, you can only put about 3/8 of an inch inside a shoe. Anything more than that, you got to put on the outside or on the sole. Growth rest is our other option. This requires growth remaining. We have the advantage of having the growth plate available. So if they have growth remaining, we can utilize that either to shut down the still growing extremity or the longer extremity. And we can also use it to do angular correction with tethering. And so generally, the lower extremities stop growing at about 14 in girls, 16 in boys. That's the rest there. Oops, I go back. Yeah, we still do it this way. Drill across the growth plate, destroy it with curettes. I've tried a couple times doing some navigated, like for a bar resection and things like that. It's kind of the technology is not quite there yet, but it's, like I said, I've tried it. Basically what you do is you stop it, the other one keeps going, and hopefully if you time it right, you equalize it. There used to be thought that you could do acute shortening, but this is not a real, it's a long recovery. I mean, you get a lot of muscle weakness, some of it possibly permanent. There's also high risk of delayed or non-unions, and a lot of people don't really want to shorten their mature height. So these are not real popular. That being said, I will do it occasionally. I like the subtroch region to do the shortening because I can do up to 2 to 5 centimeters. I can put a nail, especially if they're close to skeletal maturity. This allows me to get them weight bearing tolerated immediately, lower non-union rate, things like that. So this is an effective way of doing it. You can also correct anteversion or retroversion with this at the same time. Lengthening, which I trained a lot in lengthening. It's not dependent on growth. So that way, you have a lot more flexibility. Sometimes we're doing lengthening even on some real little kids. So like if they have a severe deformity, I might do a lengthening when they're 5 or 6, and then come back when they're 10 or 12 and do another one. And I just tell them when I do it, it's a major commitment. It takes a long time. There's often complications, but we do it. And so the general treatment rules are here: 2 to 5, lift, shorten, or lengthen. 6 to 15, lengthen once or more. Greater than 15, you're looking at a combination of things. I do like to bring up Lizroff. I actually presented cases to this guy when I was a resident in the San Francisco Fairmont Hotel once. It was just a private with Dr. Tadjan, who everybody's heard of Tadjan's Orthopedics. But yeah, he liked his vodka, let's put it that way. And cigarettes. And he liked to talk. They had problems getting him off the stage, like when they let him lecture. He'd be up there for like 2-3 hours. But anyway, he gets the credit. I always talk about the Lizroff fixator, but what's really important is what he came up with was the Lizroff principle. And it's really distraction osteogenesis. He came up with the formula that you do 1 millimeter per day And at that rate, you get proper separation without too much bone formation. He also came up with the 4 times a day kind of thing. People have tried to change those rules. People even come up with like some lengthening actuators that go like 50 times a day. But that actually formed too much bone, so they're actually getting early consolidation. So again, this thing's held the test of time, and that's from Elizarov. And here's some of the earlier ones this year. This is with an external fixator. Again, if you go too fast, prior to Elizarov, they would just crank the leg out as fast as you could, expecting to go back and have to bone graft. And they would just watch it. And if the person started getting like a nerve palsy or something like that, then they'd slow down the growth or the distraction, and they just keep going. But it was, again, with the Elizarov, they showed that the regenerate would form, and that's what kind of changed in the early 90s. The other nice thing about the Elizarov, you could do deformity correction. That's kind of evolved to these. There's a bunch of different ones out there now. The 6 struts, it's based on the flight simulators where the concept originally came up with this. But there's also it's computer generated. You have internet-based software. What's really nice about it, once you stick this on a patient, you can reprogram it to do whatever you want. You do your distractions. So if you actually like have it going the wrong way, you just redo your calculations and they can correct it, as long as the bone hasn't healed yet. I've had some weird situations where we had to do like stuff upside down, and so you got to think upside down, and then you're recalculating and you can do all that on the computer. So it's kind of nice. I think you can minimize the number of like strut changes and things like that that the patient has to go through. Here's a kid with achondroplasia. Again, we were doing it kind of early age. We're doing both deformity and lengthening. So that's the advantage of the fixators. You can do both. The real game changer currently is the intermedullary rod for lengthening. So these are fully implanted. There's 2 brands out right now, the Fitbone and the Precise Nail. The Precise Nail was off the market for a little bit for FDA reasons, but it's back on. But the nice thing about these is they're fully implanted. They're intermedullary like a standard nail. You don't have all the problems with pin sites. You also have less problems with migration of the fragments as you're lengthening. So it's easier for the patient to do this. On the left is the Fitbone, and what that has a little subcutaneous sensor right here. And then this is the external device, and you just put that up to the skin. And so 4 times a day, the patient just holds it there and pushes the button on the little box here. The Precise Nail uses a magnet, and it's similar to the what's used for the spine as well. And so this is a big device with a big ass magnet in it, and they set that on top of the rod, and you have to have it just right spot on the rod. And then 4 times a day, it makes the magnet spin, and it does the lengthening that way. So just a couple different ways of coming at it. So again, they're big advantages, and it's really kind of changed the treatment algorithm for these kids. So if you have a moderate deformity that they can live with until they're a teenager, we'll just wait until they're a little bit older and do it this way instead of doing it when they're like 10 or 12 with an external fixation, especially in the femur. I think it's made a big difference because external fixation in the femur was tough. A lot of complications because of the soft tissue. But it's, this has helped a ton with that. Here's a kid I had, he was 9 years old. He had residual deformity from infection. Talk about impingement. Look at that one. And so on him, I went in to do this lengthening, and turned out he had too much anterior apex deformity on his femur, at the proximal femur, but you don't pick it up on this x-ray. But it was right here. I was putting the nail in, he had a deformity there, so we actually had to make an osteotomy there. And then we made our lengthening osteotomy down here. Actually, I'm sorry, the deformity was down here. This is our lengthening osteotomy. And then when we started doing our distraction, he distracted through both sites, which was kind of nice because we were able to go a little quicker. And we got him out to 50 millimeters of length. Took a little while to heal. So, I threw in a bone stimulator, and then by 11 months, he was healed. Usually healing rate's about 1 month per centimeter. So he should have been healed in about 5 or 6 months. So he was definitely delayed. Then look, even his hip and neck looks a little bit better. And then here's another one. This addresses a couple of the things we've talked about. This kid had severe valgus. You can see he had an attempt at a medial tether, but he didn't have enough growth remaining, so he still had some deformity. Early on, he'd had a bar resection with Dr. Lee as my resident. But that didn't work either. So at maturity, we went in and there's a 48 millimeters of shortening and 13 degrees of valgus. So what do? We do what's called fixator assisted nailing. So you put the X-Fix on, you do your osteotomy. Again, here, see how you get the translation with your osteotomy? You just get a little bit of medial translation when you're going valgus severus, and then you get lateral translation. And you're trying to maintain your mechanical alignment. And that's what the Bovie cord's showing you there. Actually did one of these yesterday. We actually used the guide wire or the reaming guide wire instead. It's better than the Bovie cord. And then blocking screws are helpful for this. This one had a lateral blocking screw. The one I did yesterday had an anterior blocking screw. And then a retrograde nail. This is a locking nail. I'm sorry, this is the precise nail. So this is, you can actually see the magnets right in there. And that's what the external device is going to drive. And so there, you can see the distraction gap and regenerate bone right through there. Lateral view looks nice and he's scaled up, coming along. That's sort of the modern, up-to-date length in what we're doing now. Some of you guys might recognize this. It's my prone hip surgeries. I'm sure many PG2s have experienced that. So thank you for coming, everybody, and time for a break.